Hello, I'm Dr. Kim Sejin, moderator of the case discussion to share and find a solution to difficult clinical cases. Hello. To resolve problems, we have three clinical masters, Dr. Kim Kyung-won, Professor Kim Young-taek, and Dr. Park Jong-hyun. Hello. If you're watching at the demo site, you can find the real-time chatting window on the right-hand side. If you have any questions or comment, please share them on the chatting window, and let's go to the case to discuss. Hello, this is already finished case, but let me ask a question. Number 11, implant was placed in order not to invade incisive canal. The plan was to place Buckley and do GBR. As expected, dehiscence defect occurred, so GBR was done and incisive canal was not invaded, and the treatment was completed. Was I right not to invade incisive canal even with the GBR, or is it okay to invade incisive canal? What do you think? That is the story from a dentist. Let's summarize first. Is it okay to invade full-on the incisive canal during drilling? Is it okay to place an implant completely in the middle of the canal? I heard from a friend of mine that it is okay to place an implant and do bone graft after removing the nerve inside of the incisive curve, and that depressing the canal without removing the nerve could lead to neuralgia. 4. Do I have to remove the nerve to avoid the nerve depression? 5. The incisive nerve canal invasion can lead to palatal side paresthesia according to some other doctors. Can paresthesia really occur? Can the paresthesia disappear over time? And that is the question we received. The case treatment is already finished, but a similar case can appear later, so the question was brought to us to deal with the case better next time. 3 doctors, what's your take on this? In my case, regarding the incisive nerve, I don't really struggle over that because as a surgeon, for example, in the case of the globulomaxillary cyst, one of the non-odontogenic cysts, may require entire nerve removal. When the cyst involves broad area including the incisive canal, so I don't really think that's a big problem. I'll talk about this later, but depressing the nerve is not very good. Mostly the paresthesia would be transient. I think it doesn't create a problem. Also in this case, there was no problem. In most surgeries like that type of GBR, I don't think the problem would have occurred. And one day suddenly it occurred to a dentist, is this really okay doing like this? And you ask around this case with other colleagues, and you hear that it's not really good. So that's why I think the dentist gave us the question. In fact, I have not reached a clear-cut conclusion regarding this matter, but reached a sort of conclusion based on literature review. So I'm going to talk about that today. I think I will learn a lot from this case myself today. I would like to ask the viewers to think about this case together, and if you have any good ideas, please post that in the real-time chatting window. Let's hear from the 3 doctors how they would treat this case. First, Professor Kim Young-taek. Let me talk first. I looked for the information about the incisive canal in terms of what it does. It contains the nasopalatine nerve, and it has the terminal branch, and it forms anastomosis with the greater palatine nerve and artery, and it provides innervation to the palatal region from canine to canine. So it forms the anastomosis. People would know if you have opened it. If it is cut, it doesn't cause severe bleeding or swelling inside. It is just the branch, so we don't need to be too much concerned about the artery. We need to consider the nerve together. There have been so many people who have thought about it. It deserves some consideration. But how to resolve that? When you do GBR, you can do the deflation or you can bypass it around the lateral margin to position the nerve. I looked for deflation papers. Here it's not really deflation. It is drilled and an implant is placed here. According to many papers, this is used as a reference. It is cited many times. It was published quite recently in 2016. So this is a very good position for anterior implantation. That is the conclusion of the paper. So I was a bit surprised to see that. So the canal is not that important. This is my approach and also used by many dentists, and we wonder whether it is really okay. There is the nerve bundle in the canal. It is pushed in a little bit, including the foramen. The membrane is covering the site and GBR is done. That is the normal approach. If particles flow into the incisive canal, so to block it, it can be pinned down. As various papers discuss them, the non-resorbable membrane can fix the area to lateralize it. This is my case. The nerve is exposed. I really cannot cut it. I push it away and I do GBR. It is usually between 1 and 1. And if you have to place an implant there, which is rare, unless it is a full edentulous case, the place can be avoided. I looked for the information about the incisive canal. Temporary sensory loss and permanent sensory loss are reported. But according to this paper, there was just one case found to have the permanent sensory loss. The temporary sensory loss is reported several times. A problem can occur, but it is not painful. So in all the cases, they report that there is no pain. Let me introduce another case of mine. Here, the incisive canal is risen to the top. Excuse me. When you open it, you can see it. I should have raised it, but I couldn't take the picture. Here, it is here, right below the papilla. There's foramen. Intentionally, I avoided the canal. I used the non-resorbable membrane, and it is cut in a concave fashion, not to touch the canal, so that it receives less pressure. So it is bypassed with that form. It doesn't mean the nerve bundle itself is not touched at all, and the membrane goes in and it doesn't press it down so that it can be fixed. Bone graft material cannot stabilize it unless an implant is placed there like before. So this is done like that. If you look at when it's removed, the double bundle is seen here. It is placed pretty well. After second surgery and after 9 months, my conclusion is like this. If you do GBR near the incisive canal, lateralization is a good way. Not to touch it is the best way. Even though you touch it, a side effect can occur, but it doesn't enlist discomforts or complaints from patients. I have cut the canal in one of my patients. The patient complained a weird sensation in the front part of the palatal area in the anterior region during the first 1 or 2 months, but after that, the patient didn't care about it at all. Maybe it is for the anastomosis with the greater palate, or maybe the paresthesia doesn't affect the quality of life, as reported by some papers. So my conclusion is that the benefits of a surgery is bigger than the disadvantages of removing it. We need to remove it, as was mentioned by Dr. Kim. If we need to remove a supernumerary tooth, I believe we need to remove the canal to do the surgery, but still we need to bypass that canal if possible. This is too much like a textbook statement. Thank you. Thank you. Let's go to Dr. Park Jong-hyun. The nasopalatine nerve, as in the picture, is not really invaded in young patients, but in an edentulous case, it can be invaded. In most cases, it is surrounded by cortical bones, so unless you press hard during drilling, in many cases, it doesn't really perforate it. Of course, it can be perforated because the wall is not thick. However, when an incisive canal is perforated during the drilling, I get the feel. So in most cases, it is not invaded. In young patients, the surgery is completed without causing any problems. If you drill the side wall, the cortical bone of the side wall is drilled with the tapered drill of 1 to 2 kit. It doesn't easily get perforated. It can be perforated with the apex of a side cut drill. If you take CT images after placement, not many cases you can see invasion or perforation. This is a problem. If you use a guide, compared to the plane, you tend to get pushed buckly. So when I extract for about 70% of the root, I first reduce the palate with the surgical burr, then the extraction can be made very easily. And if you use a guide, it doesn't get pushed buckly. And avoid the canal like this. If I don't want to invade the incisive canal, I tend to use TS4 instead of TS3 implant. Then we can use less space at the apex. So in the anterior region, to avoid the canal, I prefer to use the TS4 implant. According to this paper, 16.7% of the canal is invaded and most of them do not have complications, and I agree with the paper. You can invade just a little bit and it doesn't cause problems, but I cannot really cut the nerve out. Ridge splitting is done to increase the width, and the incisive curve is invaded a little bit to place an implant, but there's no symptoms. So just a little bit of invasion like this has caused any problems up to now, so I don't really pay attention to that at all. But the problem occurs in cases like this. Professor Kim Young-taek showed us a paper which said this is the good site to place an implant invading the canal full on. So my question is, I entered into the canal directly with an implant and I was surprised. So I took it out and it was full of soft tissue attached to it. I tried to remove the soft tissue, but it was not easy. And when I tried to remove inside of the canal, it was not really easy. So it seems like the canal is soft tissue, and if implant is in contact with such soft tissue, is it going to be okay? I think I missed the point. I was just thinking about the foramen. What you are explaining is, I was just thinking about foramen, not incisive canal. The position and nerve bundle of the canal, that's the focus of my preparation. And you are talking about placing an implant into the canal. So I didn't think about that really. But still, I have thought about it for daily treatment. You said that the canal is not easily invaded because of the cortical bone, and I agree with you. I do not invade the area because of the soft tissue that you mentioned, and it is a nerve that can be cut. There's no disagreement to that. So when the surgery is more important than preserving the nerve, I believe it is right to go ahead with the surgery. In this case, the nerve is interfering and the nerve is soft tissue and it is not osseointegrated. I said an experienced dentist has good intuition, and if he feels something will go wrong, that will happen. When there is a nerve like that, it is not osseointegrated. Of course, osseointegration can be done in the rest of the part, but when it is covered with soft tissue, inflammation will occur. So the canal should not be invaded. If you have to invade it, you need to cut inside. And I remember I have cut once. So the bundle itself was cut intentionally like that. It was cut because it was the implant position and I plan to do GBR. In that case, maybe we can remove the implant and place it again. Removing such soft tissue and granulation tissue is not as easy as it seems. People are concerned about soft tissue attachment during flap disc surgery. I tried to remove the soft tissue, but it was not easy. If you remove the implant, it will be covered with soft tissue then. But still, there is no special instrument for the removal, and it is not easy to remove the soft tissue. Dr. Kim, what do you think? As is mentioned, if an implant is inserted into the canal, as Professor Kim said, it should be removed and the soft tissue needs to be scraped out. But the incisive canal varies greatly from patient to patient. If the canal, the hole is wide, it can be removed easily, but as Dr. Park said, if the canal is narrow, removing it is not easy. If it is removed like that, it can be removed, right? When I do the endo treatment, it is very difficult to remove the pulp in the root canal. Is very hard. So I think, is it really possible to remove the inside of this incisive canal? It is not easy to completely remove the soft tissue. The canal is in bone and the nerve and the neurovascular bundle is not adhered to any bone, so you can freely remove them. Another thing, the depression on the canal would bring ischemic necrosis, I think. So the blood supply is made from inside. However, when the implant is placed like that, the blood supply would be severed somewhere, and that would lead to the ischemic necrosis. Do you think that would cause inflammation in the soft tissue? I don't think so, but if it is twisted like that, it can happen. If the soft tissue remains on the implant, it can happen. It was not completely removed, and when I took the CT, I was surprised because it looked like that. The patient had very good bones, so I drilled another hole next to it and placed another implant right away. So in that case, the nerve is damaged, so it is like cut. It is recovered anyway, so the nerve is not that critical. What about neuralgia if it remained under depression and if I didn't replace the implant? Putting it under pressure would be a problem, as Professor Kim said before. The paper he cited, I saw that myself. One case of permanent sensory loss occurred when deflation was made. It was lateralized, not removal of the nerve. As for me, even though the nerve is lateralized and the bone graft is to be done on the site, I would remove it rather than continuously putting pressure on that. So looking at this case, I think it is less problematic if the nerve is removed rather than put it under pressure continuously. If I place the implant in the middle of the nerve without removing the nerve, I believe it would have been a problem. But fortunately, I replaced the implant again. The final prosthesis is delivered, and the patient said for about a month the palate felt rather weird. So it has some impact. After about a month, the patient said it became okay. It is not as sensitive as the inferior alveolar nerve, but still, I think, similar to incisive nerve, actually, I saw rarely the referred patients in our university who had numbness or sensation after epicoectomy in the maxillary premolars or canine. Paresthesia is complained by the patients rarely. In that case, I explain to such patients that we can avoid conspicuous anatomy like inferior alveolar nerve, but the post-superior alveolar nerve or middle superior alveolar nerve or anterior-superior alveolar nerve are all mixed together in the upper. So it is not something that can be avoided during surgery as they are in bone. We don't have any scientific evidence, but medically it is really hard to resolve when a patient complains about it. Some traffic accident patients who have maxillary fracture or infraorbital nerve numbness don't have problems, but some have problems and it is very difficult to treat them. I tried but couldn't find the information. My question is palatal nerve sensory nerve? Yes, it is a sensory nerve. Some dentist wrote an article saying it is not sensory. It is not motor nerve. Someone wrote it is not sensory. That's why I was wondering. Thank you. Final prosthesis is completed, and let me skip about the papers. The paper is about the reason for rare paresthesia. It is due to cross innervation of the greater palatine nerve and nasopalatine nerve, so it doesn't cause really problems. Anyway, paresthesia seems to be transient, except when the nerve is not removed and put under pressure continuously when the implant is placed in the middle of it. There are cases where I wanted to avoid the incisive canal. Someone fell from the sixth floor of a university hospital while doing some construction work, and the teeth were extracted in the hospital. At first, I didn't find the fractured tooth here I thought it was a fracture caused by a resident while he was removing a broken tooth. Is the alveolar bone fracture really from the fall from the 6th floor? I found it while doing a guided implant surgery, and the patient complained continuously pains, so I tried to avoid the incisive canal. During the placement, it kept opening, and I thought it is similar to the ridge splitting. And I placed the implant, and I tried too hard to avoid the incisive canal. Therefore, the implant positions were not ideal. So the gap between the central incisors is too big, resulting in non-aesthetic results. At week 12, we can see the fractured portion is healed. If it is placed a little bit mesially, the embrasure would have been formed better. So in the anterior region, I do not try to avoid the incisive canal. Aesthetics is more important. Unless an implant is entering into the middle of the nerve completely, I put higher priority to the aesthetics. At about month 7, the fractured line is being healed. If the fractured part is not completely fallen off and partially attached, and the periosteum is still attached, in the fractured portion, an implant can be placed. That's what it seems. Listening to your comment, I believe the resident would feel unfair. I believe the fracture is from the fall, not from the extraction. The root tip remains, and I thought it's from the extraction by a resident. My apologies to the resident. Anyway, I was relieved to see the fractured portion is healed. And I want to say with this case that incisive canal is not to be avoided to sacrifice the aesthetic ideal position of an implant. Here, the embrasure is invaded. Going back to the question, let's summarize what I think. Can I invade the incisive canal during drilling full on? I don't know. I do not want to invade it too much. Invading just a little bit would be okay. And I could not find any evidence regarding placing an implant in the middle of the canal without removing nerve. I believe Professor Kim Kyung-won would add more to this. It has been 4.5 years since I left the university hospital, and I wanted to find a case to show you clearly the incisive nerve or X-ray, but I could not find them. I managed to find just one case, and the patient has non-odontogenic cyst. I don't remember the patient's age. It is a globulomaxillary cyst, and you can see protruded part beneath the nose. The palatal side is also swollen. As you can see, the incision is made, and if you raise the flap labially, it is protruded and it is thin. Now the cyst is all removed. There is no canal and nothing. The nerve is completely removed. In that case, pathology can occur, so I explain it to the patient. After the surgery, I say paresthesia can occur in the inside of palatal or lips. Mostly they are transient, and as I remember it, the patient did not complain of it. I tried to find some pictures relevant to the case in question, but I'm sorry, I could not be able to do so. I couldn't find it partly because I didn't really thought it's serious to consider the canal. I think I showed you this case before. If you look at this patient in 2010, there is the impacted canine on the maxilla. The patient had mobile central incisor and the lateral incisor and wanted implant placement, and was not accepted by many clinics, so the patient was referred to me. In the intraoral standard, you can see the canal, and on the CT, when we extracted, actually, the impacted canine is hung over the canal. Central and lateral incisors are removed, and the lateral incisor is pushed inside like this, and there's no room for placing two implants. So it should be placed in the central incisor site, and the canine is extracted with the bone on the labial side maintained. The impacted canine is cut from the root little by little, and we try to maintain the bone on the labial side. So the TS3 implant was placed, and you can see on the apex it is a little bit touching or invading it. It is covered with the allogenic bone and collagen membrane, and GBR was done. Immediate post-op and the secondary surgery. So in the images, you can see it is slightly invading the canal. If I was thinking about seriously the canal, I might have some images that I can use now. At that time, we didn't use the CT, but medical CT, so I don't have the CT images. At the second surgery, the bone was covering, so it is removed, and the surgery was done. Panorama pictures after 2 years, so there is no problem. And as Dr. Park, incisive nerve is many dentists seem to be concerned about, and I looked for some relevant journal. In this paper on incisive canal characteristics, the study was done with 933 subjects in 4 dental clinics. The canal length was 10 millimeters and mean diameter 2.59 millimeters. Canal length was short in edentulous maxilla compared to the dentate maxilla, and canal diameter did not show any difference between dentate and edentulous groups. It seems like the width of the canal varies from person to person. Males had a longer and wider canal than females. Canal shape was mostly cylindrical, and there's no correlation found with mean dental length and diameter according to age. That is what is reported. And the conclusion of the paper is that variations exist in every patient, and clinicians should perform careful planning using CT scans before performing dental implant surgeries. Then there'll be no problems. That is how it is concluded. This paper, I believe this is the same paper cited by Professor Kim. It was published in 2017. The success rate and complications associated with dental implants in the incisive canal region. 10 articles were reviewed, 91 implants, and the success rate ranged from 84 to 100%, which is not significant. The 3 articles reported temporary sensory loss, and 1 article reported a permanent sensory loss. As I mentioned before, it was not deflation, but lateralization caused the permanent sensory loss. That means, I think, about 20 years ago, I tried the lateralization, a couple of cases of inferior alveolar nerve, and I never did that again. This is different from the inferior alveolar nerve, but as Professor Kim said, if it were me, I would remove it, and I wouldn't do the bone graft, just pushing it aside. The bone materials pressing down on it would create problems. So severing the nerve would be better anyway. Incisive region, as reported by the paper, we need to evaluate the site. And according to the paper, we need to get the full consent from the patient by explaining the situation. However, unfortunately, when we consider the complications, when we predict the numbness or complications or damages, when we cut the nerve, I tried to find the parameters associated with that, but I could not find them. That means we cannot accurately predict what will happen. So there's great uncertainty when it comes to predicting complications. If the nerve poses a problem in the site where we are going to place an implant, as Dr. Park said before, it is not good to go into the canal. In general cases, we don't really need to be too much concerned about that, as long as the implant positions are correctly made. So we heard from the three doctors regarding today's case. Going back to the case, would you give us the final comments based on what we have discussed? As for me, I don't think I would sacrifice the ideal aesthetic position for incisive canal. It would be a problem if we go into the incisive canal full on. However, in the anterior region, aesthetics is the most important factor, and ER type, for the ER type, placement direction is very important. So in this case, I would have placed implants invading the incisive canal palatally. I would not sacrifice the direction of the placement for the aesthetic results, not to invade the incisive canal. I think a little bit differently. There are cases we need to invade them, and it is impossible not to do so. Sometimes we have to cut it, but we should not depress it. But we have the CBCT, and we can clearly see the canal, and I cannot place it over it. I wouldn't do it either. I would not go near it. If possible, I will discuss it with the prosthodontist in advance, and I will leave the aesthetics to you, and I want to place the implant here, so I try to evade the canal. So unless it is absolutely necessary, I try to avoid the canal. There is a conflicting opinion maybe between me and the prosthodontist. The surgery can become very complicated for aesthetics. So if I invade the canal, inflammation can occur, and complications later can become a headache. So I'll explain it to the patient. The aesthetic may be sacrificed to avoid the invasion. Based on research, 16.4% of the people's canal have been invaded, so just a bit of invading can be done for sake of aesthetics, right? Considering the thickness of the cortical, invading 1 millimeter would be okay. The diameter of the canal is 3 millimeters, but I would not invade half of the canal. I wouldn't do that either. But we need to avoid it as much as possible, but invade the minimal amount. We cannot completely ignore it. I think so too. I agree with Professor Kim. If we did not have cone beam CT, it's different, but the case under discussion, the dentist position the implant properly using the cone beam CT. We also have very nice tool of digital guide, and if you can get good positions, we don't really need to be too much concerned about the invasion, we have some room for invasion. Let me ask just one more question. I think the dentist who asked the question did pretty well, but I would go more palatally. What do you think? Using a digital guide, I believe we can go more palatally. Based on the analysis, it is almost touching the canal. Yes, you can do that. You use TS4, and if you are using a tapered implant, there will be no problem. And there are many ways to recover using prosthesis. Okay, I'll take your advice. To summarize what we have been discussed, first we need to avoid the invasion as much as possible, but minimal invasion can be made for aesthetic reasons, which is more important. So there has been some differences of opinions among the doctors, but as much as possible, we need to avoid the invasion, and we do not depress the canal. And TS4 implant can be more favorable in this type of a case. In this case discussion, we talked about whether invading incisive canal would be okay in placing an implant in the anterior region. I hope today's discussion would be helpful for you if you encounter a similar case down the road. Thank you very much, doctors. I'm Dr. Kim Se-jin. I'll see you next time. Thank you very much.
감사합니다.
감사합니다.
수고하셨습니다.